All right. Good morning, everyone. Welcome to the grand rounds for Santa Grace Emergency Medicine. It's February 1st. This should be our residents and faculty only this morning. If you are a guest, please join us back at around 10 a.m. And we're happy to have you join us for the rest of the day of grand rounds. Today, I'd like to introduce a very special guest of ours, our one and only DIO, Dr. Jarrett Weinberger, here to present about ACGME Site Visit that's upcoming in the very near future. Take it away, Dr. Weinberger. Thank you.
Thanks. Just want to make sure everyone can still see the screen and hear me okay. All right. I want to thank Dr. Vilela. Also want to thank Colin McMahon, Dr. Walker, and Dr. Kattiar, who let me shadow them for a brief moment this Friday morning. So I was living the life of a Sinai Grace emergency medicine physician, and it really gave me a new perspective as it relates to the struggles of holdovers and how they impact attending resident interactions and the overall educational experience. So I want to thank all of those involved. And I appreciate them kind of opening up a window to the GME office so that we can better serve all of you. As everyone knows, we have an ACGME site visit coming up next Tuesday, and it can be a little scary for everybody involved, from PDs to program coordinators to residents. And really today's session is really just to get you in tune to what you can and should expect, and also to help prepare you as it relates to discussions with site visitors and things like that. So make sure. So the goals for today, number one, is just to give you an overview of what the RRC is, who site visitors are, and how they all fit into the supervision and accreditation process of the ACGME. It's important to understand how they're linked. Provide you with a few strategies for preparation. We are not here to create a script for you to follow. We don't want you to be overly rehearsed, and that's oftentimes identified by field staff as an issue at times. We want to really encourage open and honest dialogue, but also to convey your own personal experience. And if your personal experience differs from somebody else in the meeting, that's absolutely fine, and it's absolutely encouraged that you share your experiences. We also want to highlight some of the areas that are likely to be discussed during these site visits. Although we're not 100% accurate in kind of guesstimating where topics of conversation will be, usually we're pretty accurate in terms of areas of opportunity within the program and what might be discussed during the site visit. And again, that last thing is to open up honest dialogue with the site visitors. I think you've all probably had some time to reflect in larger and smaller groups, whether it's APEs, about the successes and opportunities of the program, but also the threats that exist out there, both intrinsically and externally as it relates to your overall experience. So who is the RRC? The RRC is the entity in the ACGME that will make the accreditation decision. They have other roles and responsibilities as well, which I'll talk about on the next slide. But one of the primary things they do is review a whole host of data, including information that's uploaded in something called the ADS, Accreditation Data System for the ACGME. Dr. Vilela and the program coordinators basically work year-round in updating that document, and that's an important piece of information. But we also know there's two other pieces of information that are probably more important per the RRC, and that's the resident and faculty survey, number one, and then any site visits that go on. These are really considered to be the crux and critical information. As you can see, for the ACGME Emergency Medicine RRC, there's 15 voting members. There's some public members. There's a resident member as well. And they have a couple dates, one in February, one in April, where they have their committee meetings. They review all the documents, and then they make an accreditation decision. And then there's some of the specific members at large. So as I said before, their job really is to review the compliance of your program with the common program requirements as dictated for emergency medicine. They, in addition to the information I mentioned before, they also look at board pass rates, case logs, and things like that, if it is applicable. In addition to deciding on your accreditation status, they also work on program requirements. They talk about policy and procedural changes within the ACGME as well. But we're going to focus a lot on the site visit data and how we can prepare as a group to have the best possible interaction with the site visitors. Just a reminder for those of you in terms of accreditation status, there are various statuses that can exist. Right now, we have continued accreditation in emergency medicine, and you guys have enjoyed very successful accreditation decisions for a very long time. If there are areas of opportunity or concern, at times you may get citations and still get continued accreditation. If there are numerous citations, you may go to a continued accreditation with warning. And there's a lot of different prompts from the ACGME as it relates to what cues them to come on a site visit. We have been told by ACGME, owing to the convenience of virtual visits, that we are likely to see an uptick as it relates to the number of site visits. So I don't want everybody to hear a red siren and start to panic that we are in immediate concern for the program, because I think Dr. Villela has done a great job. And actually, in reviewing much of your survey, for the most part, most of the areas are still very strong, and if not at, above national means. And then we have other concerning things like probationary accreditation, withdrawal of accreditation, that can exist, but I don't anticipate, owing to the strength of the leadership in the ED, that any of these will become a concern for us in the near future. There's a quick picture of many of the field staff. So who the field staff are the individuals that are hired by the ACGME to actually conduct the site visits. They are not members of the RRC. What they do is that they review all of the data that I talked about, the surveys, they review the ADS, they review a lot of other requested materials that come from Dr. Villela and the program coordinator as it relates to evaluations or semi-annuals, and how they document all of those, and certain policies that they request, which have already been reviewed and submitted to the field staff. They then create a report. That report is part and parcel with all of the information I mentioned before in the accreditation decision in terms of the RRC. So it's important to understand that the field staff do not make any specific recommendations. They actually are gathering the data, trying to see if there's anything concerning that they identify kind of at the grassroots level. They want to verify information as it relates to policies, resident understanding, faculty understanding of policies, and things like that. So you guys will have 2 site visitors. It's a long bio. I guess everybody signs a required requirement that we always put on a few slides that have way too many words and nobody will ever read. I don't anticipate or want you to read everything that this is. I have a summary slide after this, but Dr. Caniano is one of our site visitors, and we're glad, although both of our site visitors have kind of a lean towards pediatrics, they are both very experienced site visitors, and they are both physicians. So they have lived the reality of what it is to be a resident trainee, what it is to be a faculty. They've also held numerous other leadership roles in terms of chief operating officers and things like that. So many of them have a lot of experience in leadership positions and really do get can get the pulse of the program because of their lived and learned experiences. So as I said before, she is a physician. She did lots of pediatric surgery, critical care. She is an experienced site visitor since 2010, and she has focused much of her work on teaching and education. So it's important to know a little bit about your surveyors, because it's likely that their interests will also pour into the line of questioning that they may ask. So Dr. Caniano might be particularly interested in your didactics and how those are handled and who attends those, how they're structured, how you provide feedback. And so it is important to know some of their basic interests and things like that as well. And then for Dr. Villela, take to solace in that this person was a former PD. So they also understand your roles, your responsibilities, your struggles as it relates to filling such an important position as well. And then the other one is Dr. Grossman. She also is a physician, again, with a pediatric lean, but she has some more operational experience as a COO. So she may have vast experience in operations of throughput in ERs or on the floors and things like that. And so that brings in kind of a nice different slant to the types of questions that Dr. Grossman might be asking as it relates to her interactions with you as well. And again, she's a relatively experienced site visitor as well. So let's talk about the site visit topics. Usually, site visit topics will be aligned relatively well with the resident and faculty ACGME survey from the previous year. Not 100%, not all the time, but certainly we have consistently seen alignment in those areas. And these are some of the major areas and topics that are covered in that survey. And I've highlighted a few of those that I think through some of our internal surveys and then looking at the ACGME survey and in previous discussions and in rounding and shadowing for a brief while, I've seen as realities for each and every one of you. First is service to education imbalance. And I think that the key term in there is non-physician obligation tied into that imbalance that can be perceived, especially when you're starting all the IVs, when you're placing all the Foley catheters and things like that. Program resources, safety and health conditions. We've had particular focus at Sinai Grace Hospital. I have a couple slides regarding that as well. And then a process to raise problems and concerns. And I don't know exactly how all the survey questions are phrased, but my gestalt for many of you in conversations with both faculty and residents isn't necessarily like, I don't know how to bring up these issues, or I'm scared to bring up these issues, because Dr. Villela is extremely supportive in all of our interactions of you as trainees within the program. I think it has to do with how quickly is my feedback translated into concrete change. And that was identified as a major area of opportunity by myself when I took on the role. I'm not quite a year in the position, but coming close, as well as Joe Catney's the VPAA, who some of you or many of you probably have also have interactions with. And one of the most important things we've done is really try to open up a consistent and regular dialogue and help with transparency as it relates to these issues as they're brought forward. And I'll talk a little bit more about that. I think the great thing for your program is that Colin now is the site representative for Sinai Grace. So you guys have a direct tie to the resident council member who meets monthly with the CEOs, with the COOs, as well as the GME office, where we track all of the issues and concerns that are brought forward. And those are always available via Excel spreadsheets, and Colin can send them to you as well. I'm hoping he also sent some successes shared by the GME office in the resident council recently. Dr. Marina Hack, who's the communications director for the resident council, put forth a document with some of the shared successes, space concerns that were resolved and things like that. And we are fully cognizant that we have to kind of dig out of a little bit of a hole as it relates to some of the space and safety concerns and things like that. And I'll talk more about that a little bit later, about how we've restructured the communication and the reporting mechanisms for you as well. And then patient safety and teamwork. One of the primary issues that I wanted to come in and shadow Dr. Katia and Dr. Walker was to see how you guys on a day-to-day basis are interacting with nursing staff and other ancillary staff, because I think that in and of itself can make or break a shift or a month or your entire training. And so my eyes were opened to some great opportunities as it relates to teaming and partnering, particularly with nursing staff, social work care managers, and things like that. So this is your survey. And as you can see, many of these look very good, okay? Evaluation, educational content, DEI, clinical experience, which is AKA work hours, okay? Faculty teaching, even those are a little bit of a decline, still above the national average or national mean. Areas of opportunity, and believe me, when I see this break here, I look at these and I think these are things that are very heavily dependent internally on the program, Dr. Vilela and other leadership and faculty. And man, if you look to the right, all of those seem very strong, right? When we look to the left, we start to see potential impacts of institutional oversight, institutional support, and the trends are not as good. And I recognize that. So we're going to talk a little bit about resources, professionalism, patient safety, and teaming, and some of those next ones, because I think there's been some real concrete examples of areas of opportunity, and I want to talk about how they were addressed at times, and how they will continue to be addressed moving forward. So here's a few areas. We look at these percentages. Again, this is data coming directly from your resident survey. None of this information should be new. I know Dr. Vilela, he may go over in a separate time, but definitely this is something that oftentimes will drive discussions during your annual program evaluation and things like that. The first one is no surprise, and it's what I was leading off and talking about, that education to service imbalance, and it has to do with those non-physician obligations. There are some things that are clearly physician obligations, some things that are clearly not physician obligations. Sometimes there's a small gray area where it could or could not be, and that can cause confusion. But I don't think in the reports that I've received and what I saw, there's a lot of confusion from the side of residents who are reporting these concerns. Transport should never be really a physician obligation unless a patient is critically ill and they need a physician to walk with them in the bedside. But I don't think I've ever received any concerns or complaints from residents from situations similar to that. And so I know that I have a few update slides from Brittany Lavis, who presented in our GMEC, I think last week. So Dr. Vilela may see them, but there is a specific focus in the emergency departments, particularly as it relates to throughput, ancillary support, and nursing. I know you have a new ED director. I know Dr. Vilela speaks very highly of her. She's an experienced one, so it's not like it's a new third party having to learn everything about the emergency room. She knows about it, and has already partnered really, really great with Dr. Vilela and the rest of the emergency medicine team. And we count on your collaboration from those standpoints as well. Satisfied with safety and health concerns. We had issues where somebody thought maybe they saw a gun or a weapon, code silver, and things like that. And we, again, identify opportunities as it relates to real-time communication to all of those involved. And I'll talk about what we, as an institution, how we're responding and some of the things that we've done. I'm assuming many of you have already had or received the training as it relates to code silver. I know Colin has been a great resource in connecting the training with the individual programs over at Sinai Grace as well. And then, again, I talked about the able to raise concerns without fear or intimidation. I think it's more so, when do we see concrete change? We can say things till we're blue in the face, but if nothing changes, you become apathetic. So we're cognizant of that as well. Information not lost during shift changes, patient transfers, and a handover process. This is not as simple as it seems. Maybe back in the heyday when there weren't so many holdovers, it was a matter of who's left in that mod or that area that you have to sign out, and that was essentially the sign out. But now you oftentimes see yourself and your attendings oftentimes are walking into 15, 20 patients on hold, and it's a lot more akin to maybe an internal medicine sign out where you are still have oversight of those individuals and nobody else has assumed care at that time. But I do think there's also opportunity to standardize it within the program a little bit. And we'll work with Dr. Vilela as it relates to the skull and crossbones, how we're going to use that sign out, how we have oversight to make sure that that information isn't lost, because it is a critical component. And I think in much of the data, as it relates to duty hours, many errors occur during these sign out. These are the most vulnerable times for patients in terms of transition of care. And then we want to integrate you guys in safety event and investigation analysis. I have taken the lead and asked Brittany Lavis to send me every MIDAS report that either involves a resident or is submitted by a resident that we can identify. Sometimes they come in anonymously and it's hard to identify, so that I can partner with PDs and with you as residents, because these have to be learning experiences. We've reached out to Sharon Menzel, who's a great resource for patient safety and quality, who gave a great presentation on culture of safety and root cause analysis, and what you as a resident can expect when you're called to be part of a root cause analysis, because it can be scary and intimidating. And one of the things that we've always wanted to make sure is that you have appropriate faculty oversight whenever you're pulled in to those events, to help you understand, answer questions for you that you may have, and so that you don't feel like you're abandoned or alone or anything like that. Dr. Villela may recognize this slide from GMEC. I took it directly from Brittany Lavis. And so there's a couple things. We're talking about recruitment and retention. And when I say recruitment and retention, I know there are a lot of open positions, but I think critical to throughput in the emergency department is going to be nursing staff, care managers, and social workers. I had a great conversation with Amy Hamilton, who is acting as the group CNO, and I have no idea, but the DMC has hired, or over the past year, for the year 2023, hired 520 nurses, which is a pretty large number. And it's great, and we've made some progress in that area, but we still have a heavy reliance on some of the travel or agency nurses, and they may or may not have the same buy-in and commitment to the institution, and we acknowledge and understand that, and are working towards aligning goals and expectations for nurses, working with the CNOs from that standpoint. We also understand, as we rev up recruitment, it also means that we have a younger, maybe less experienced workforce, particularly in nursing, coming in. And so we have to be cognizant of that. We still have a fair amount of amazing nurses who are still committed to the area, who do a lot of that onboarding and orientation for those nurses coming in. In terms of retention, hiring 520 nurses would be meaningless if 700 were lost over that past year. And for a while, Dr. Villela can attest that no matter how many people we hired, we were always in the negative as it relates to nurse staffing. We're finally starting to see a trend where for a while it was stable, and now we're seeing an actual uptrend in the overall number of nurses. But we still, as I said, have that over dependence, like many institutions, on the agency nurses, which is a clear focus moving forward. Every employee that comes in now receives a 30, 60, 90-day interview to make sure and see if there's anything they need to do to make their job satisfaction better. I also have heard many people concerned about what the starting offers are for nurses, and it's hard to recruit anybody if you're so far below the market in Southeast Michigan. And again, Amy Hamilton was very open and transparent with me that a year and a half ago she could not have said it, but they reevaluated and realigned all of the initial pay structures for nursing throughout the institution, and she said they are competitive with essentially all of the hospital systems in Southeast Michigan. But she gave the caveat that that information is usually very tight-lipped, because it may or may not improve recruitment by not disclosing what your offerings are abroad to the entire community of hospitals in this area. The other area of particular focus is operations and efficiency and throughput in the emergency departments. And I understand this is not just how quickly you see them and move them out. Much of it has to do with, are the acute care floors appropriately staffed? How many holds you're walking into? So it's a complex issue, but the goal is to get the DMC functioning back to where it was pre-pandemic, where you had your 29-minute guarantee, and we were the fastest emergency medicine department in Oakland and Wayne counties. And we've seen significant improvements over the past several months. but our goal is still to get back down to about 144 minutes or so back in those kind of most efficient times of ED throughput. And so we certainly appreciate all of the support and collaboration from you guys, from the leadership. And I'm hoping with your new ED director, we can continue to see improvement from that standpoint. And we have seen some signs of improvement, even in surveys. It's not as bad as it used to be, but we recognize and want to celebrate the successes, but still acknowledging that there's a way to go. A few other things specific to safety and security at Sinai Grace. And we've had lots of great conversations with Colin, the site director or site representative, along with other residents as well. I know there was a time when there were several thefts, cars broken into. This does happen. None of us want this to happen, but soon after, and Michelle Morasso, who's a CO, I want to give her a lot of credit, and she has been thoroughly engaged in addressing these issues whenever they come up. And I also want to thank Joe Cantonese and all the resident council members who have been actively engaged in identifying and mitigating these issues. With all of the cameras, both internally and in the parking lots, were upgraded and updated and or fixed or replaced following, I think it was like 3 or 4 vehicles at one time that were broken into. We've also discussed the possibility of a heavier fence instead of like that arm that goes up and down. We've removed the physician parking sign because that may be more appealing for passerbys to go into that lot as opposed to any other parking lot surrounding the hospital and things like that. We are still short on security personnel. As you can see, at last date, there were still 7 openings to be filled in terms of security. And so they are actively recruiting, and this is another area where they have reset the initial pay scale for all of those individuals as well. I know Dr. Villela, myself, Joe, and all of you had conversations about the security car and whether or not it is a blank, empty security car or if it's really doing patrols. I did reach out to Joe Cantonese this morning. I know we had those conversations. He hasn't received any pictures of the empty vehicle since our last meeting, but I don't know if Dr. Villela has as well. But this is a priority for us. We want you guys to be safe. We want our patients to be safe. And then one of the greatest areas of opportunity was during immediate emergency issues, code silvers. Whether it be somebody with a weapon, active shooter, whether it be a bomb threat or anything like that, there was a major blind spot as it relates to real-time communication, particularly with people in the hospital. And so it's still being implemented and coming forward. I know many of you have had some specific training on Code Silver, but there's a tenant alert system that will, in real time, based on your preferred mode of contact, which I think most people are actually putting in cell phones, give you updates about any emergency situation that arises, similar to that Code Silver, where people said, we didn't know anything till it was over, or we found out from social media. Now, I can't promise that the tenant alert system will beat social media. I don't think anybody can necessarily keep up with the speed of social media, but all of you need to know, especially when you are in an area potentially of threat. And so that's something that is at the highest level of our executive leadership that they're working towards. There's other future goals about partnering with the DPD as it relates to the green light cameras, and I'll try to give you guys a more concrete update moving forward. And that's that parking lot area with a heavier gate and things like that. So these are some of the things, and hopefully Colin can send you some of the other concrete changes that come from your feedback. And again, I wish these things, and Dr. Villela wishes these things could be done overnight, but many of them have a lot of layers of complexity that even we didn't realize when we bring forward and start working with executive leadership in how to resolve and mitigate these issues for you. So a few other things that are concerns that actually came out in some of the internal surveys. One was that there was a thought that we actually decreased the contact with residents in the GME office after the restructuring. And it couldn't be farther from the case. And so I think the previous model under Dr. Uddyback was basically she would meet with the resident council, and then she would meet with the kind of body of the residents. They'd bring forth issues. She would work the next month to mitigate what she could or wouldn't, give you an update. And that kind of just repeated itself month after month. Clearly, it wasn't working. Many of the issues seemed to drag on forever and ever. And so Joe Kentney's and myself immediately created a new structure in partnership with Shiv Misra and all of the resident council site reps, where you guys can put these issues into new innovations. There's a tab for resident space concerns or whatever it may be. It goes directly to your site rep. And every month, we in the GME office meet with the resident executive committee to go over these issues, to provide updates. They're all updated in real time. We also meet with each site representative and the appropriate CMO or CEO for that site. In addition to that, we have quarterly large updates to the resident body as a whole, which I think makes more sense for large updates maybe every quarter as opposed to every month to the resident body, because it does give us in the resident council time to make and affect some of those changes. In addition to that, we have additional meetings with the PDs in the site CEOs and things as well. So in the past, where it was upwards of 2 hours a month of contact, real face-to-face contact, if you include all of the different sites, all of the different meetings between site reps and PDs, we are now at the table with residents on the sites upwards of 10 hours a month as opposed to 2. And I know that doesn't seem like a lot because you don't always see the things going on in the background, but it is a lot. And we are committed to making those changes concrete and real. And if you have questions or concerns, you guys are very blessed to have the site rep right in your program. And he's done a great job stepping in, really taking over for the previous site rep. And we didn't see any skip in the step or progress that we've been making. So in terms of the site visit itself, this one will be virtual. I think all of you are probably skilled and schooled and experienced enough to know about virtual hygiene. And the ask of our program or of the GME office would be very similar to this being a professional interview. Making sure that your lighting is appropriate, not having spinning fans behind you and those things that act as distractions, making sure your mics are working well, and things like that as well. Now, we've seen, I know this next sentence says invitations come directly from ACGME Site Visitor. So we've seen a little bit different style of site visitors. Some will send it directly to you. Others will engage program coordinators to send it to you. And it's really dependent upon the site visitor. I think be on the lookout from your program coordinator, because I think the invite may come from her this time. Be on time, sign in 5 minutes early. If nothing else, just to make sure that your connection is working. And you can usually test both your video and your audio prior to that as well. Most of you have it, but if you can just make sure that you change your name, put your first and last name. It makes it much easier to communicate, because remember, the site visitors don't know you. We always recommend, and you don't have to now, but we always do recommend that you use your camera unless your battery is dying or anything like that. But we would hope that you make sure that your battery is charged and you're good to go from that standpoint, and try to appear on camera the entire duration of the meeting as well. If you need to, take a backup device and other things like that. And don't panic if you become disconnected, just rejoin. This is what the site agenda looks like. There is an initial meeting, a 2-hour meeting with Dr. Villela and the site visitors. Lots of questions. They will go over a lot of documentation. They will go over many things in the ADS, and it really is kind of a grind for Dr. Villela. So let's make sure he's well caffeinated and he eats a good hearty breakfast to get through those first 2 hours. And then what they'll do is they separate each and every one of the PGY years, because we understand, and this ACGME understands, that the perspective as you go through training changes immensely. And I know most of you, that when as a PGY3, if you look back at your experience as a PGY1, what you perceive and what you understand now is so vastly different. And I think that's one of the reasons why they model it based on PGY levels. Plus, it's a more efficient way to do it, as there's 2 site visitors and they can alternate between the various years. Again, we encourage open, honest communication, and really convey your experience, your personal experience, both good and when there's areas of opportunity. One thing I will say about the ACGME, that they've always said they're not looking for the perfect running machine as it relates to a program, because that doesn't exist. What they're more cognizant of is, what are the modalities and mechanisms that you communicate? Does leadership listen, and are there efforts to make changes? And hopefully I've demonstrated a few of those changes. I know Dr. Villela is constantly making small tweaks as it relates to your overall experience. For instance, we had a nice, frank discussion about some of the psychiatric holds, and how he and the faculty, who I want to commend, have really taken the brunt of that and said, listen, if we get a sense that somebody is overly aggressive in terms of their posturing and things, we don't even involve residents, and we will see and take care of those patients, which I think is commendable to his character, and really the support of the faculty throughout your program as well. There will be a meeting with myself as well as the department chair. These are often very kind of large, kind of overarching questions about organizational structures and things like that, how we support PDs and other things like that. And then there's another meeting with Dr. Villela and the coordinator. There may be things that were identified, and then throughout the day, Dr. Villela will have to get them and then provide them. And they do give some feedback at the end as well. It's not detailed to the point of whether or not they think the decision will be favorable or unfavorable, but they certainly will give kind of a general gestalt of the tone of the residents, of the faculty, in the direction that the program is moving in as well. We covered a lot of this. Let me see. One thing that we all do, I think we're all at times psychologically programmed to focus in on negative components of something. I know as a clinician educator, I could look at 60 good evaluations of my teaching performance, and if I get one, that's the one I think about and dwell about for hours and hours or days and days. And I'm sure if you received any type of critical information or feedback, you felt the same way, despite how much good there is. And I do always want to encourage you to be honest and talk about areas of opportunity, but it's also okay to talk about some of the shared successes. It's also okay to talk about some of the wonderful opportunities, about the depth and acuity of pathology that you're exposed to. The fact that you're probably going to be more ready than about 99.9% of emergency medicine graduates. When you walk out the door, you're going to be really prepared for anything and almost everything that walks through that door. And it's okay to also celebrate those successes and talk about them with the program or with the site visitor. It's good to talk about your interactions with your PD and your faculty and how they support you, or areas of opportunity if those also exist. Basics: be on time. If you can silence your phone and your pager and things like that, that would be greatly appreciated. And as always, try to answer the questions that they ask. And if they want more information, they can ask more information. You don't have to fill in every detail that has ever existed when they're asking you an overarching or a broad question and things like that. They may ask you about how do you provide feedback to leadership, and then how is that followed up on as it relates to improvements or changes within the program. And you can actually cite two processes if not more, as it relates to kind of internal programming issues that you speak with Dr. Villela, but also the mechanism through which Colin works on your behalf as a site rep to take care of other things that are concerning or areas of opportunity. Again, this is more likely a tax audit, and it's a professional interaction as opposed to dinner with friends. I'm not going to require white coats. I know as emergency medicine residents, you probably put your white coats away on day one, and you may get it out later on in your third year or on a few rotations. But certainly, if you could just wear professional attire, I think it would be strongly encouraged as well. Having said that, I want to leave time and space for any questions that any of you may have on the faculty side and or Dr. Villela.
No questions for Dr. Weinberger?
Let me look at the chat. I see a few things. Okay. No questions in the chat. Something worth reading, though. I may click on it.
Dr. Weinberger, are you sending me these slides?
I can send them to you right after we end this meeting. Yep.
Great. Thank you very much.
All right.
Well, we want to thank you very much for coming today and joining us and providing a map to the site visit. Thank you again for all your support.
Not a problem. I want to thank you for your leadership and everyone else's involvement too. It's really the only path forward for all of us.
All right. Thanks again. All right, everyone. We will be breaking out shortly into our sessions for Foundations of Emergency Medicine. Faculty that joined us, thank you so much for being here. Residents, as a reminder, we'll be discussing candidates that we interviewed that also rotated at Santa Grace at the end of the grand rounds today, in the last hour, actually. So if many of you can hang on till then, that's great. But those that have to go, we understand. And if you have other questions about this, please don't hesitate. I just received some possible questions that you might receive, a list of them. I will forward that to the residency so you all can take a look at what you might expect and understand the angle of these questions and the information that you might want to consider letting them know. And again, as Dr. Weinberger mentioned, it's important to just be honest and just answer the question that they're asking. The time goes by very fast, I can tell you. It seems like, oh my gosh, 45 minutes is so long, but they can go by pretty fast. So a couple other notes on that day. Next Tuesday, you will all be off of service for that time. Maya has sent emails out to all the off services as well as the emergency department to remind them that you will be stepping away based on your year. Maya will be, I've asked her to provide some little food up there. So if you're up there during that time, we'll have some fun sustenance for you all. And just to make that day a little bit easier if you're in the hospital. And as mentioned, of course, if you're not in the hospital, please dress professionally and also while in the hospital, obviously. And that way you'll show well. And then please get on a computer or your laptop. They're not enjoying any iPhone or cell phone to log into. But again, as Dr. Weinberger mentioned, if there's some emergency, just let them know what happened, so that way they can understand why you're not on your computer. All right, Dr. Kate, are the rooms actually all the?
Hey Matt,
what
was it that prompted this, or is it just a scheduled routine thing?
You mean the site visit?
Yeah.
So thanks, Stephen. It's a great question. So the site visit's multiple reasons. So our last big site visit was 2008. We had a site visit they used to be every 3 years. The last one was 2011, and it's been a while. So we were actually scheduled for one in 2018, and we had been pretty much being reaccredited with commendation or just reaccredited, no problem for many years. We got pushed to 2019, then 2020, and then pandemic. And then, of course, pandemic, quote unquote, lifted last April or May. And so they got back to doing these site visits virtually. So one of the biggest reasons, one, we haven't had one in 12 years or more, 15 years. Number two, the surveys. And as some of you may or may not know, the reflections of the surveys are not too dissimilar from DRH. And as some also know, that the impact of the surveys are quite direct on the residency programs, and I think rightfully so. And that's how they kind of measure what's going on in programs. And so I think all of it in combination precipitated a site survey for us. I can tell you that DRH had a site survey about 5 years ago, and they got another one already. So again, it really varies with what's going on, but feedback from the resident surveys has shown a very quick response from ACGME to lead to a site survey.
Hey, Mav, I have a question too. So like, it's no surprise that like our main complaint, like you said, is like staffing issues, which isn't a reflection on the program at all. It's a reflection on the hospital. So like, is there any chance of non-accreditation because of like things that are outside the program's control for ranking the program highly, or not really?
So Becca, that's a great question. We always hope that it will not lead to closure, stuff like that. The ACGME is not out to shut down programs. That is the last thing that they want to do. The RRC, who are the direct members that actually look at our program and do the actual decision making, many of them are emergency physicians, and many of them are PDs or former PDs or leadership in all of medicine, who understand the challenges nationally and regionally and locally. That's why the site visitors are really coming to help gather more information, to be boots on the ground, so to speak, to connect with all of you, all of us faculty as well, and to kind of help decide what's going on. Are the concern, the big thing I think is, are the trends there that are showing nothing being done? Or are there trends there that we understand that ups and downs happen, but people are trying? And I hope that what we've been trying to express to you is, that there's a sincere attempt to make movements forward. And it's not just talk. The data is showing it out, and sometimes the feeling of the change may not happen, or does happen. It just depends on how you're experiencing it. But thankfully, again, that is not the goal, is to shut programs down. They're trying to provide better practices or best practices as examples. They're also trying to provide kudos to the successes. But again, they are looking for weaknesses. They are looking at the weaknesses. They're looking for trends that are negatively trending in order to address and follow up. So again, that survey that was being shown is something that I've shown to all of you multiple times in grand rounds, and faculty have seen during the monthly faculty staff meetings, and we've discussed in different arenas. Some of you may not remember, you may not have been here, but they've definitely been discussed at the annual program evaluation, as well as last year I discussed it right after we received it. And then of course in the fall, and then last month. And again, I know some of you won't remember it. It was displayed a little differently than what you're used to. We're going to show that a little bit later as well at the end of grand rounds after we do the candidate review, just to kind of let you guys all see everything again in a little bit more time if you need to. And if you want to really look at it, let us know. We can share it with you if you come in person to the Maya's office or my office. I'm happy to share with you, or go over it on Zoom with you directly with more time. And again, it's the kind of thing that this was based on the class of 22-23. So some of it is data from our most recent grads, but that's just how the survey works. The survey is done in that particular year, then the events follow, and I hope that the changes are addressed or being addressed, and that's really the goal overall. And well, the overall goal is to make it a lot better, which is what we need to do. And institutionally, as was mentioned, there are changes that are happening, but fear of closure for that reason really shouldn't be a real fear. But I can't be 100% to be honest, but in experience and talking to people, that wasn't the reason. There's a lot of room to be penalized, so to speak. Of course, you never want to get penalties. There's if everything's fine, everything's fine. You might have a comment about AFI, which is called Area for Improvement. But when it becomes an issue where you have violations, that's when your program can go to uh, probation. So continued accreditation is accreditation with commendation is the highest. Continued accreditation is the most common thing that most of our programs get. And then you can have continued accreditation below that with probation. And then you can have continued accreditation with warning. And so there's a few steps that they kind of give room for programs that are having, whether it's core residency issues, or if it's hospital issues or system issues, it gives them time, as Dr. Weinberger was trying to show in that picture, of a year or two to respond.
Yeah, I'm going
Does
to
that
jump
answer?
in. Mav
Oh.
is being a little tentative. You have an excellent program. You may receive a few citations, but you have an excellent program. They're coming now. They're coming virtual, which makes it nice. If they were really worried about you, they would have probably come in person. They're doing what their job is. So they had, 3 areas of major concern of the residents: safety, decreasing their teaching, secondary, other ancillary, and anonymity when they actually are bringing out faults. Receiving was just reviewed, and I was very clear with them that if you look at the complaints there, they're not really directed at the department themselves. They're directed at a different level, and Mav is right on. So what they want to hear is that you have a plan of action. You've done a root cause analysis. You've changed some things to try and make things better is the whole key moving forward. And then you track that data, but the program's not going to be shut down. There might, maybe a few citations, but the citations should directly go to GME. And I don't know, Matt, what your usually technique is that this is a huge, this is an opportunity to tell the RRC where you think the problems lie, not only within your department, but within GME and other places. And I'm very direct with the last one and hopefully this one too there, but they're not shutting down your program. No question about it. You have an excellent program.
Thanks, Brian. Thank you very much. And Becca, I'm sorry, I was trying to answer your about the white coats. Yeah, just if you have them, bring them. But honestly, it's a business or professional dress. That's what they want to see. I just want to remind everyone, Dr. Caniano has been a long-term surgeon and a pediatric surgeon at that. So I describe her as someone who's going to be very kind, but with a firm hand. She is definitely someone who's on point with things and very specific. So she will even look at your clothing. So again, if you're going to work, scrubs is fine. Just let her know that you're working or on shift. If you have your white coat, Becca, pull it out. But if you don't have either, just professional dress. Showing that respect to the site visitor is really important. I haven't met Dr. Grossman yet. I was hoping that she would be on the little quick meeting that Maya, myself, and Dr. Delcourt had with her last week, just to make sure that we're all together in understanding of what's expected of us. And so I'm not sure what her demeanor is. So it'll be a little bit of a new introduction next Tuesday when we meet with both of them. And of course, as a reminder, half of you residents in each class will meet with Dr. Caniano, and the other half will meet with Dr. Grossman. If you have any concerns throughout the weekend or Monday or Tuesday, don't hesitate. I'll be up all the next several days, just reviewing stuff, but also to answer any questions. And as a quick reminder, we'll talk a little bit more and have time for more questions this last hour of Grand Rounds for any and all of you. So thank you all for coming today. Please, for those that have not been able to join us, your colleagues, please let them know Dr. Dolcourt is recording this, and we'll, cut it down to, this hour for specifically for any of our residents and faculty actually to look at and review. I encourage those of you who know some of your classmates that maybe weren't able to come for multiple reasons to just encourage them to watch it in case they just want a little quick update on some of these things. And of course, reach out to any of us directly, not just me, but anyone, any of the faculty who can answer questions for you, Maya and Emma. And oh, just a quick reminder, residents, please have everyone a copy of your list of, strengths and weaknesses that you all created. Please have it available to yourselves individually, as they might be discussed during your time with the site visitor. All right. Any other comments from anybody or questions? Okay, cool.